session. And turning over so multiple people can share the screen. That's for you, Steve.
Okay.
Good morning to everyone. This is John Fitzpatrick from KC Digital Drive. I help to organize these meetings on a monthly basis and every now and then a evening forum or other kinds of things, as well as a few projects. I'm in my private life, I'm a consultant strategic marketing in the global environment, particularly in digital health. And very happy to see everyone today. I'm pretty familiar with most of the folks here, but it'd be really nice to go around the horn here and do introductions. And so Steve, I might go ahead and start with you. Good, please.
You bet. Thanks, John. I'm Steve Kropp, the Director of Telehealth at the University of Kansas Health System. Been with KU about, say 15 to 18 months in relationship to building their telehealth program and working with some really motivated people here at KU around telehealth. Been in healthcare in Kansas City area for about 30 years and really enjoy the opportunity of helping underserved or rural populations get the care they need and without disparity as far as the quality of that care. So telehealth kind of fits in that mold.
Great, thank you. Matt.
Sure, Matt Heelan. I'm the Chief Operating Officer of a company here in town called Lunasoft. We're a custom software development company. We mainly specialize in healthcare.
Robert.
Sure, hi, I'm Robert Stiles. I'm with the Department of Pediatrics at KU Medical Center and work with the Heartland Health Resource Center. We're really pleased that about a month ago now, the Office for the Advancement of Telehealth put out 3 different grants and we got all of them. So we're also now becoming a telehealth training center. We have an evidence-based telehealth grant. And so altogether, about $1.2 million a year in funding that will allow us to continue all of our telehealth work, including the technical assistance of the Telehealth Resource Center.
Oh, that's fantastic. Congratulations. Thank you for taking the time to announce that here. It's good news for all of us. Jenny?
Hey, good morning, everybody. I'm Jenny Marshall. I am the Director of Research for the Heart Center at Children's Mercy. I am also kind of in a transition phase of being the Director of Research for Remote Health Solutions within the Innovation Center at Children's Mercy. So I'm kind of working both worlds right now. But I've been at CMH for 20 years, and I am very interested in home monitoring and how that can help our patients.
Great. Maria.
Hi, I'm Maria Flynn, Managing Director of Techstars Kansas City. We're an investor and accelerator program, and we're happy to bring in Gradient here today.
Yes, thank you very much. So it was through the auspices of Techstars that we came to know Gradient Health, our presenters this morning, so we're very grateful for that. Ron?
Hey, Ron Whiting. I'm the Executive Director of KC Health Collaborative, a regional multi-stakeholder health improvement collaborative. We've got work focused mostly on social determinants and health equity. Happy to be here.
Great, thanks, Ron. Anurag.
Good morning. My name is Anurag Patel. I'm CEO founder of Abada Health. We help move healthcare data from one organization to another, as well as do analytics in primary care. I'm also on the health innovation team for Digital Drive.
Great. William.
Hi, everyone. William Crumpler. I work as a AmeriCorps Vista Digital Inclusion Program Coordinator with KC Digital Drive.
Great. Gary?
Hey, good morning. I'm Gary Carnes. I'm our Telehealth Program Manager at the University of Kansas Health System. I've been with the team for about 6 months. Prior to that, spent a couple years in informatics nursing here at KU. And if we go further back, history of cardiovascular nursing out in Southern California. Pleasure to be here today.
Yeah, welcome, Gary. Matthew.
Good morning, everyone. My name is Matthew Cheffa. I'm with the Center for Practical Bioethics. We're a small community-based not-for-profit bioethics and medical ethics stuff. And I am the ethics lead on our ethical AI project, which is exploring the ethical dimensions of artificial intelligence in healthcare. It's a community-based participatory action group.
Great, thank you. Jim.
Jim Starsov. I'm the program manager for Solutions Lab at KC Digital Drive.
Doug.
Yes, I'm Doug Hohulan with Nokia. I'm working on various telehealth and educational projects.
Great. Tanya?
Hi, good morning, everyone. This is Tanya joining you from Dubai on behalf of OmniLife. Just recently joined OmniLife as a business development manager and looking forward to hearing from all of you.
Great. You're calling from Dubai, you said?
Yes, that's right.
Oh, welcome. Great
you.
to have you.
Thanks.
Josh?
Hey, I'm Josh Miller. I'm the CEO of Gradient Health. Happy to be here with you all today.
Great. Thank you. I'm glad to have you with us. Todd.
Hi, Todd Ike, On and On. We capture existing conditions.
Okay. Lucia.
Hi, my name is Lucia. I am a senior program manager for social determinants of health and the maternal program for United Healthcare in the state of Kansas.
Great. Aaron.
Hi, everyone. Aaron Deacon, Managing Director of KC Digital Drive.
Ashley.
I am Ashley Smith. I'm a clinical informatics nurse at North Kansas City Hospital.
Great, welcome. Chris, I won't ask you twice this time.
Good morning, Chris Kelly, Health Information Manager for Johnson County.
Great. Larry. We're just doing it. Larry's still connecting to audio. Are you with us, Rich?
Yep.
Go
yeah,
ahead,
Rich Murray,
yourself,
Healthcare. Yeah, Healthcare Consulting, Omaha, Nebraska, and Arizona in the wintertime.
Good for you. Larry, looks like Larry's still connecting. Why don't, Larry Heffling is joining us. He is a healthcare consultant as well. Looking forward to his participation, but why don't we just jump quickly? We have one sort of advertorial to start off with today. Matt Heelan's organization is sponsoring a public event in December, and I'd like him to just tell us a little bit about that so that we might consider participating.
Sure, thanks, John. So on December 7th, from 11 o'clock to 1 o'clock, we're sponsoring a webcast called Exploring Remote Patient Monitoring. We're currently looking for panelists to join us, and just to give you a flavor for what we're looking for, both people who are designing and building those types of solutions, and also physicians and nurses who are actually kind of, in it every day that are using it and seeing the benefits of it. And then also looking for executives to be able to present from their organization or from their healthcare network to kind of describe the impact that it's having on their organization and the people they serve. So if you are interested, you can email me at, and I'll throw it in the chat, maybe it's matt.heelan@illumisoft.com. Thanks.
Yeah, if you could go ahead and put that in the chat, that would be great, Matt. Thank you.
Will do, thanks.
Okay, great. Well, let us kick off then. I'd like to reintroduce Steve Kropp, the Director of Telehealth for the University of Kansas Health System. He's our presenter today, supported by his colleague, Gary Carnes. Steve, welcome you to let us know more about what's happening in telehealth at KU.
Great, thanks, John. I'm going to do a quick screen share, and hopefully we can move through these in about 20 minutes. Visited with John yesterday, and more of telling our story than it is trying to educate you guys. Most of you are well aware of the benefits of telehealth. I don't want to bore you with those things, but I do want to maybe expand your thoughts in some areas that we haven't talked about, at least in the last few Digital Drive discussions I've been included in. So if I can share, and then if someone would just let me know when you can see my screen, that'd be great.
Looks like we're good to go if you want to go ahead and expand it.
You bet. Does that work?
Perfect.
Very good. Health system at a glance. I mean, most of you are aware, if you live here in the Midwest, of the breadth of KU. We won't spend much time here, but it's just interesting to know that as we're growing mainly west. and looking at how to serve the rural populations in Kansas with telehealth. All the numbers on the right kind of give you a flavor for how big and kind of the shoulders that we have to build on at KU. But I think the most important thing is that we have an appetite for technology and innovation that was really fueled on the telehealth side by the pandemic. And we'll talk more about that. Also, recently in the news, you've seen some of the things about U.S. News and World Report. Again, information that is known in the Midwest, but we like to really wave that flag every now and then because it does give an example of the focus that we have on quality healthcare and how telehealth is now being used to expand that care to people who may not have had access. So when you think about telehealth in our particular neck of the woods, if you will, or neck of the prairie out here in Kansas, we're trying to think of how we can make a bigger footprint for telehealth in a digital world. Everyone since last March has become much more of an expert on telehealth. And the 3 or 4 things that are above the waterline, everyone's doing. Ambulatory, I mean, you'll see the numbers. We went from doing 15 a week to about 1,200 a day. Direct to consumer, all those things are being done. Even Blue Cross and Blue Shield here in KC, they offer a direct to consumer product as an insurance carrier to patients that are looking for telehealth. And then urgent care and then inpatient. Those are all things that are being done on a fairly regular basis across every health system. Now, the things that are below the waterline are things that I think we need to really be thinking about. And from a KC Digital Drive, I thought about, the things that would interest you. I think there are huge opportunities in rural sustainability. Rural hospitals are closing at an alarming rate. I think there are some statistics that show that, the work that's being done there is critical, but the reimbursement and the sustainability is questionable. RPM, which was mentioned, I think, John, you and your team are looking at different ways to focus some attention on RPM, which is remote patient monitoring. The thing that's not talked about much is ancillary services and how ancillary services in healthcare could include pharmacy and lab, rehab, all of those things that could support good healthcare. We don't talk a lot about. We usually talk about the physician and the patient interaction. Obviously, improved access, payer engagement, hospital at home, and another thing is implantables. We're right now at KU providing in our cardiac heart failure or CHF program an implantable monitoring program where once those devices are implanted, we're able to monitor them for that patient so that we look at expanding that and kind of rolling that into a much larger footprint for our RPM program. As most of those are being done departmentally right now, we want to see those things being done systemically. Not that everyone's going to get an implantable, but that implantable monitoring would be an element or a component of the greater RPM package at KU. We talked a little bit about this as far as being above the waterline, real life experiences shaping patient opinions. Everyone's opinion has evolved over the last 18 months about telehealth. I'm sure that if we went around right now, everyone on this Zoom call would be able to maybe share an experience they had with a telehealth provider. Maybe it was an urgent care, maybe direct consumer, maybe with your standard or your established primary care physician, but somewhere along the way, a growing number of the population have experienced those. Interesting, the dollar value associated with this. When we're talking about over, $100 billion, most medical economics experts are recognizing that those elements that are associated with good telehealth programs have the potential to explode, and not only because of the pandemic, but also the post-pandemic work that's being done to really get an understanding about how telehealth can change our healthcare models going forward. I think we could all agree on the 4 points. Telemedicine is here to stay. Previously, when I would do presentations with another organization across the state line, I would always ask the audience, does anyone want to venture a guess or prognostication that telehealth is going to retreat at some point in time? Someone's going to raise their hand and say, you know what, this isn't a good idea. We're going to go the other way. And it's a rhetorical question, but it's really good for us to fix in our minds that this is here to stay, and we need to figure out how we can appreciate and leverage every aspect of telehealth and the technology associated going forward. Patients are primed for virtual care. Even those that were holdouts, both on the patient and the provider side, have sometimes dragging their feet come into a world where they need to recognize the value of virtual care. Reaches untapped markets and also the long-term positive health impacts, which I think the group that you're pulling together in December, on December 7th, will help even further that and punctuate that thought relative to remote patient monitoring. Moving quickly through, John had asked if we could tell just a little bit of our story. Real quickly, in 2019, if you looked at the plan going forward at KU, we had a 3-year telehealth rollout business plan. And we would select a telehealth video vendor. All of those elements that we all know are in good project management, good processing and project plan and workflow. 3 to 6 months to integrate telehealth into our Epic EMR. Our strategic goal was to complete 10,000 video visits in the first year. Man, that sounds like a lofty goal. Then maybe 100,000 over the second and third year. We would start small, 2 or 3 specialties, and then expand slowly by interested departments. The initial focus was on needed specialties in Greater Kansas, which we're continuing that aspect right now. This slide I wanted to throw in because it emphasizes all the different ways that telehealth can touch a patient at the bedside. And as we found out on our ambulatory experience last year in 2020, that it grew exponentially. When we see the opportunity, the sweet spot, if you will, for telehealth right now is more on the inpatient side and then the post-acute or the remote patient monitoring, which my colleague Gary will talk about in just a moment. I think one of the things that I really wanted to emphasize is that the only limiting or restraining factor that we really have is ourselves. I mean, if organizations can experiment just remotely on the value and the benefit of connecting with patients and keeping them healthy or encouraging them to stay healthy, then that appetite will help fuel additional telehealth programs going forward. We all know what a hockey stick graph looks like. I think that's what we experienced in our telehealth growth last year. I wanted just to point out a couple of these bullet points here on the left, and it has the potential for better coordinated care, but we also run the risk of fragmenting healthcare. Fragmented care may lead to gaps in care, overuse of medical care, inappropriate use of medications, or unnecessary or overlapping care. That's why, and we really want to emphasize the importance of integrating whatever telehealth program you do, whatever way you go as a health system or as a independent group, to make sure that it's integrated into that patient's healthcare record. Somehow, some way, it needs to find that information, needs to find its way into that health record so that we can make sure the communication flows bidirectionally and that patients get the good care without falling through gaps. The other one is the potential benefits of telehealth services. It's going to be limited by other factors, such as reimbursement. We know that insurance reimbursements for telehealth still vary across the nation. Even CMS, we're still trying to sort out going forward. Another point John wanted us to focus on, what does the next iteration of healthcare look like, especially on the reimbursement side? I wish I could sit here today and tell you exactly what's going to happen. I have a educated guess, if you will, that we're still going to see reimbursement, but that reimbursement is going to be a lowered rate for telehealth services. So if I'm in a bed in a hospital and I have a physician that walks in and sees me and manages my care, there's going to be an elevated reimbursement for that versus that physician being in his or her office and coming in and managing my care through a virtual setting. Moving on, I know this doesn't look like a very pretty hockey stick, but as you can see, that was the growth that we experienced from March of 2020. And again, I don't want to even begin to take credit for the growth of that on the telehealth side. There was a true army of people at our university and our health system that made these things happen. This just gives you a quick flavor of our story. Telehealth go live after 1 week of planning, unintegrated with Epic. We had to start unintegrated because we knew that the integrated portion would take too long for us to get patients seen that needed to be seen. We met 2 times a day with live telehealth tips and tricks. We even coordinated a happy hour so that after work, if people wanted to join and learn how to do telehealth, we had providers, we had schedulers, we had a whole host of folks joining. By the numbers, we did 80 telehealth patients on go live day. Now, quickly moving forward, we saw 10,000 patients seen via telehealth by end of week 3, our original first year goal. So this just gives you an idea of how that lift was orchestrated. I'm not going to spend much time on this slide. Most of you have probably seen this if you've had any contact with SG2 or with KPMG or any of the consulting groups. This really does a good job of outlining every touch point in the process or the continuum of care where telehealth can have an impact, a positive impact on patient care, starting at the home all the way going through that high acuity or that acute experience at a hospital and then back to home through remote patient home monitoring. And again, I know we were limited on time, so I won't spend time, but I would be glad to visit with anyone afterwards if they'd like to talk more about this slide. I'm going to transition over to Gary now and really thinking about what the chronic care business model looks like. The bottom left corner of the screen, you can see 90% of the nation's 3.8 trillion, that's with a T, in annual healthcare expenditures are for people with chronic and mental health conditions. So if you think about that 90% spend, is there a way that telehealth, remote patient monitoring, and virtual health, virtual care can help alleviate some of those chronic illnesses that are mentioned at the top? So Gary, I'm going to turn it over to you at this point.
All right, thank you, Steve. So remote patient monitoring and telehealth. Okay, so we've heard and witnessed how the pandemic has impacted individuals' ability to engage with their healthcare. And Medical Express reported that 1 in 3 adults delayed or skipped medical care during the pandemic, and 58% of those that needed care skipped a scheduled preventative care visit. It's also worth noting that those percentages gradually increase as the patient location becomes more and more rural. So these skipped preventative care visits put patients, especially those with chronic illness, in a vulnerable position and at a great risk of having to visit the emergency department and potentially getting admitted to the hospital. So we've also recognized how the pandemic has, oh, Steve, could you go back a slide, please? Thank you. So we've also recognized how the pandemic has forwarded the digitization of telehealth and brought more awareness to remote patient monitoring, or RPM. So as an important piece of virtually caring for the patient. So providing a proactive preventative healthcare to patients is the right thing to do, and a well-implemented RPM program can help facilitate the effort tremendously. So RPM is a valuable tool that can aid physicians to get a clear picture of a patient's healthcare prior to conducting the virtual visit. So the monitoring leverages wearables and medical devices to transmit patients' biometrics, i.e. blood pressure, blood sugars, weight, temperature, all via Bluetooth to either a dedicated tablet or smartphone application. And then by having dedicated nurses remotely monitor the patient's data, providers can be notified if an intervention is needed with their patients. So I have a quote here, and this is from Renaissance philosopher Desiderius Erasmus. Prevention is better than the cure. Okay, next slide, please. So patient benefits of RPM. Common RPM use cases are for high-risk patients. So these patients have been diagnosed with diabetes, congenital heart failure, hypertension, COPD, or a combination of those chronic illnesses. Studies routinely report patients enrolled in RPM have a higher patient satisfaction rating, less visits to the ED, lower rates of hospital admissions, and if they do get admitted to the hospital, they have reduced lengths of stay. So recent cases and studies have also reported that patients having a greater success in their disease management due to the higher level of accountability and reporting the biometrics. Along with higher satisfaction ratings in their healthcare management, patients have also shown a reduction in anxiety and depression while in RPM, partly due to the empowerment of tracking their health along and partly due to regular check-ins from RNs to help manage their care. So I've got a great example here of a patient success story that was on our RPM program with Kaiser Permanente. So, and this one probably resonates with me a bit more since I'm a Southern California kid at heart, and you'll hear why that matters here in just a moment. So, okay, so the patient had been diagnosed with diabetes for about 10 years, and recently his blood sugars were becoming more and more difficult to maintain. His uncontrolled diabetes led him to be identified as a high risk for hospital admission, which followed by him being placed on the RPM program. So within the first 30 days, they identified his blood sugars were spiking, and now what seemed to be random nights of the week. So the RN that was monitoring him found it curious. There didn't seem to be a predictable trend when his blood sugars were spiking at night, or so they thought. The care monitoring team reached out to him to review his diet, insulin dosage, and why his sugars could be spiking. And through the conversation, they discovered he was a Lakers fan, and he was treating himself to popcorn every night there was a game. He thought that the low-calorie, low-fat popcorn diet that he was eating was a healthy food choice and didn't realize it was causing blood sugars to spike. So this discussion with the RN helped turn his life around. He quit eating the popcorn during Lakers games and continued to routinely track his blood sugars while on the program. And with guidance and accountability from the care management team, he was able to further reduce his A1C. But it didn't stop there. Over the course of the next 6 months, he continued to fine-tune his diet and proceeded to lose an additional 50 pounds, reduce his A1C even further. So this is a great example of how RPM changed life, in this case for a Lakers fan. Next slide, please. So also financial benefits of RPM. So again, in healthcare, we understand taking care of patients and providing better patient outcomes is why an RPM program should be initiated to begin with. However, there are also opportunities to reduce the overall costs of care through these preventative healthcare measures. And as more healthcare systems transition from fee-for-service models to value-based care, the need to provide preventive care is even more apparent. So the National Association of ACOs reported that the Medicare Shared Savings Program, that's the accountable care organization model that serves approximately 10.6 million seniors, it collectively saved Medicare $4.1 billion in 2020. A large portion of these savings are due to preventative healthcare practices, such as remote patient monitoring. And as I previously mentioned, high-risk patients enrolled in RPM have less ED visits, low rates of hospital admissions, and when they do get admitted to the hospital, reduced lengths of stay. So here in bullet points are a few examples of RPM success. Frederick Health had achieved exceptional savings with their program monitoring chronic care patients from October 2018 to April of 2019. Frederick's Health Chronic Care Management Telehealth program monitored over 250 Medicare patients, each for about 6 months. And over that 6-month period, hospital readmissions among the telehealth patients was reduced by 83%. And that resulted in nearly $5.1 million in cost savings for that health system. Penn Medicine saw a 30-day readmission rate decrease by 53% among heart failure patients. Hackensack Meridian Health was able to reduce hospital readmissions among CHF patients by 71%. So again, common trends with the studies as far as reduce ED visits, reduce admission to the hospital, and reduce lengths of stay, and also higher patient satisfaction. Next slide, please. So the future of RPM. So as technology continues to advance and more devices are approved by the FDA, RPM capabilities will continue to expand. Now imagine going to your next appointment and being asked to stand in front of what looks like a mirror. Within moments, a full non-invasive biometric workup is completed. Beyond your standard vital signs, your body receives a full biometric and genetic scan. You're then provided with a custom tailored diet and exercise regimen for the day. The additional data, which has been integrated into your electronic health record, is reviewed by a physician and assisted by artificial intelligence to determine if there's been any breakdown in your genetic code or if an abnormal cell growth has been introduced to your system. Now imagine if this is all done from the comfort of your own home, or better yet, any place or any time you choose through the advancement of wearables and smartphones. So that's the wonderful part of health technologies and telehealth and RPM. It helps clinicians prevent and manage illness, all while meeting the patients where they are. So this ends my part of the presentation, and I'll hand it back over to Steve. Thank you.
Thanks, Gary. And John, just to kind of wrap up our portion of the presentation this morning, Dr. Denton Shanks, he's our medical director for telehealth. And I asked him to participate. He's actually seeing clinic patients this morning, but he did share a couple of slides that I thought were very important for us to see the way that telehealth emerged. I mean, a lot of us were doing a lot of foundational work prior to the COVID pandemic. And a lot of that foundation work allowed us to build even higher through the pandemic. But interesting concept, if you think about it, that we thought about the whole time from March when we started this 2-week lift to get all of these things completed to do our Epic integration. It was like building the plane while we were flying. And we kind of used that as our mantra. Every time we would have an early morning meeting, sometimes at 6:30 or 7 in the morning, and then maybe a happy hour at 6:30 or 7 o'clock that night to educate everyone on what work had been done that day to build our telehealth program. They understood the concept that we're seeing patients daily now with our telehealth program. But we're rebuilding and rethinking that plane so that it can be integrated into our EMR, our Epic EMR, while we're flying the plane. It was a magnificent experience. I think the learning will be used and leveraged for many years to come. But I want to just emphasize this bottom part is the fact that each team member stretched their time and effort as far as possible to get telehealth up and running in order to provide the best care to our patients during the public health emergency. Dr. Shanks concluded that we wanted to do everything we could to get patients reconnected with their healthcare team. I know that from Gary's comments about anxiety and depression, to those that have chronic conditions, maybe diabetes or others, they needed that regular contact with their providers. And we wanted to make sure that that was being looked at from a a patient standpoint and to be able to do the very best thing we can for our patients, which is the mantra here at KU. This is our closing slide, and many things that people have experienced during the pandemic have helped them understand what the benefits of telehealth are. I just want to emphasize a couple of things here, and basically the idea of promoting social distancing. There are periods of time in our nation when healthcare makes some rapid advancements. I think we've made some advancements in healthcare that we're not going to recover from. One of them is the way we look at the waiting room. I mean, you think about the way that your waiting room is for your internal med physician or other providers, is that, a lot of possibly marginally or acutely sick people are thrown into a waiting room, and everyone's in that pod there together before they see the provider. Many of you have probably gone to see a physician in person, and you've used your car as your waiting room. And then you're contacted either by a text or a phone call to say, now we're ready to see you. I think there's a lot of things that are going to evolve, not saying the waiting room is going away, but I think the way that we look at that for patients that maybe have an acute illness is certainly changing. I think the idea of quarantining and addressing asymptomatic, allowing providers and staff to continue to work remotely, mitigating the loss of highly needed resources. We put together a program at the beginning of the pandemic for our emergency room physicians, who many of them had traveled just the week before the quarantine to offsite locations for education and training. Well, when they returned, they had 14 days where they were completely pulled out of our lineup for our bench strength and ED physicians. And we ramped up a program where they could actually manage patients that are non-acute patients that are coming in through the ED or through our urgent cares, where they could see them from their home. They weren't symptomatic, but they had to verify after that 14-day period. So that was another good use of telehealth. Transportation and mobility barriers, and then better care, better access, better provider experience, and better patient experience. I think when we look at this 10 or 15 or 20 years from now, I think it's going to be seen as obviously a monumental, pivotal point in the way that healthcare is delivered in our nation. And I'll pause there and close. John, is there anything else you'd like for us to cover in our talk this morning?
This has been great, Steve. Thank you very much. I have a comment and a question to start us off, but I was just wondering, is there any sort of advocacy that's necessary right now for final rules or legislation or anything like that? Is there things that we should be getting behind in order to advance telehealth?
Great point. Most of you are probably familiar with the ATA, which is American Telemedicine Association. I think we had a couple of representatives from the Heartland Telehealth Resource Center. There are a lot of different advocates out there working for the advancement of telehealth. I think the biggest one we can do is just make sure that our state legislators and our national Congress members are aware that there is a very strong groundswell of support for the permanentization or basically making permanent the idea of telehealth reimbursement. And again, I believe we're on course for that, but I don't want to see it be such a low reimbursement rate that it's detrimental to the growth of telehealth. So by all means, the biggest advocacy we can do is make sure that our legislators and lawmakers are aware of the need for this and the importance of it from the folks that are doing the voting.
Great, thank you. As I said, I have a comment and a question. First is the comment. I have been consulting in this space for 30 years, and it actually is due to an engagement I had with KU a long time ago with Dr. Gary Doolittle in the telemedicine area. And I had the opportunity to visit with oncology patients that he was managing out in Hayes from the main campus.
Yep.
And it just said very early on what the possibilities here were. And I'm just really, as I said, since I've been in this heart and soul for at least 30 years now, it's just so great to see your program covering as much as it does, RPM and ancillary services and so on. To me, telehealth had too narrow of a definition. It was viewed as just a consultation between a physician and a patient, whereas to me, it meant everything tele in health. And it seems that that's really what's happening in your program, that you're reaching out not only over distance, but over time. And that is being able to do things asynchronously with the patient at his or her convenience at home or wherever they might be. And that aspect of telehealth is really something I've been promoting for a very long time. And it's so great to see it happening within your program. I'm really impressed.
Good point, John, about the asynchronous. Most of you are aware that synchronous and asynchronous telehealth. I know that our friends over at MU have been doing a very strong asynchronous dermatology clinic for a long time. And they're doing this part as some of the state grants were available to them. But I think that's something we're going to see emerge even stronger in the future. You know, one goal of telehealth has always been to be able to rapidly transfer knowledge. And if, you know, we're doing that in communities like Great Bend, Kansas right now. We started actually this month a tele-infectious disease program in Great Bend, Kansas. There was no chance that they would develop a an infectious disease consult program in Great Bend. But because of telehealth, we're able to rapidly transfer the knowledge of our very strong ID group to the city of Great Bend and the patients that access that point for care. So we're excited about that.
That's great. And then my question, and this is, I feel I'm sort of the strategy guy, but I've actually got a technology question. And that was, I know that KU Health System had looked very seriously at what video modality they would use for telehealth. And I was wondering where you ultimately landed there in terms of security and so on.
Yep, good question. We did look at several, and partly because of the need to do the rapid build, we actually use a Zoom application. But I know a lot of folks were kind of shying away from that at first just because of security issues, but because we require it to be password protected. And we go through a certified Zoom security, we found it to be extremely secure across all networks that we use for telehealth. We also have an inpatient service that we use through a company, a proprietary company that we use for inpatient services and video. It's a little different than Zoom. And it's a proprietary network that's very secure. It's used nationally. So that's kind of the two areas that we primarily use for that. We're still in search right now, and Gary's leading the charge for our remote patient monitoring in determining what service or what vendor we would want to go with in that particular realm.
Great. Okay, I've captured way too much time here. Let me open it up to others for questions.
I think I saw a question from Ashley Smith. Actually, I don't know if you want to ask that or if you just want to leave it in the chat. I think it was about being able to add a third-party interpreter.
Yeah, I didn't know. I mean, I'm sure your patient population is very similar to ours in the fact that you have patients that require interpretation. I know something that we struggled with at the beginning was how do we connect them with an interpreter as well as with the telemedicine physician or specialist.
Yep, great question, and you're spot on with that. We worked. It was about it should have been about a 3-month build. We worked in about a week and a half to 2 weeks during the buildup in the pandemic of being able to incorporate that and make sure that's integrated in that patient visit, so that if the physician or actually the schedulers recognize that this individual or this patient needs to have an interpreter included, they go ahead and make sure that link is available to our certified interpreters, and then they're able to join that experience or that encounter with the provider, the patient, and their family right at that same moment.
Do you ever have an instance where they may not know in advance until the physician gets on the call and realizes, hey, I need an interpreter right now, and they have to go get one?
You know that the world isn't perfect, don't you?
Unfortunately, yes.
Unfortunately, yeah. And that's exactly the situation that we found as we look at our need for that. Ideally, the schedulers would recognize that, but in the event that they don't, then we do have the ability to reach out to those interpreters. And we tested that. Dr. Shanks, who I mentioned during our presentation, he was instrumental in us being able to test that pathway for that workflow to be developed for interpreters to be brought in simultaneously.
Great, thank you.
You bet. Thanks for the question. John, you're on mute.
You're muted, John. Yep.
Yeah, that's usually the case. There's a nice comment in the chat from Amy Roberts I direct your attention to. Other questions from the team?
Steve, this may go a little bit outside You obviously switching over from the medical center versus the School of Medicine, but are they starting to really train? Do you know if there's any training going on to, as the students are coming through to be doctors, nurses, et cetera, to practice telehealth?
Jim, it's a very appropriate question, and the answer is yes. To what degree that training is taking place, I think it varies all across the nation in every med school. If you noticed in Dr. Shanks' portion, we really worked hard to make sure that the students and residents during that build-up last year were included in our rotation for telehealth and the way that we manage patients. So they got a crash course, kind of like our normal providers did. But going forward, I think that's one of the things that we're going to see a pivotal point in the history of healthcare in America, is where we began to make sure that students, nurses, physical therapists, others coming out, that they have that woven into their educational process. So, we've got to be thinking about tomorrow, and that's one way to do it, is to make sure that those students coming out are very comfortable with technology. Most of them are, simply because of the compote or the importance of telehealth and technology as they go through their educational process. But even now, it's kind of like it's on steroids, in the sense that they have to be able to use it for their own care, but also as they're providing care for others through their particular specialties or disciplines.
I have another question, sorry.
No, actually, you're only allowed one per session.
So you talked about like rural expansion and stabilization. So with telemedicine, I know a lot of times the struggle is internet connections, technology availability. How did you guys get around that?
I can say with complete honesty, we're still getting around that. It's not something that we've scaled by any stretch. I think, more and more rural facilities in Kansas are getting better coverage. As I mentioned, we just recently added a program at Great Bend. And prior to doing that, our IT team went in and they really completely upgraded and rebuilt their whole Wi-Fi infrastructure. And for patients that are living outside of that area, it is still a struggle. Even patients, there are pockets of care that needs to be provided that can't, even in metropolitan areas. And part of that is just through the diversity of patients that need to access telehealth. And we're trying to mitigate those things with a lot of different programs. I know Gary's working on that with the RPM and figuring out ways that we can still give patients that access to care, even though that bandwidth may not be there, or they may have a difficult time getting equipment and technology into their hands.
Thank you.
Mm-hmm.
Yes, the technology piece is very significant. And one of the organizations that Kansas City Digital Drive works with is called PCs for People. And they work primarily in the urban core in helping people acquire equipment at very low cost, also Wi-Fi hotspots. So fortunately, there are some resources available in the Kansas City community to help address that need. Not that it will ever be universal, but certainly there are some real diligent efforts being made.
John, I would be very interested in getting that resource if you would be willing just to send us the contact for that. I think as we continue to provide care for patients all across the region, that would be helpful for us to maybe partner on some of those that patients stand in need of.
Absolutely, very, very happy to share that.
I agree. Yeah, would that be something you'd be able to share with the group, or?
Yeah, let me, while we move on to our next presentation, maybe I'll go ahead and get the contact information and get it into the chat for everybody.
Thank you.
I've got one question, if I can, John, before we close. I'd like to have a question to the group. And if someone would be willing to volunteer, not necessarily with KU, if it's with KU, great. If it's not, that's fine too. Would any of you be willing to share maybe a positive or a negative experience you've had with telehealth? We're always learning from, even if it's not our program, I want to learn from how those experiences are being accumulated out there. And if you'd want to share, not necessarily the issue or the acute issue you went to see the physician for, but if telehealth worked for you or if it didn't.
John, we have time for one more question, or are you trying to move on?
Well,
Steve?
I just thought we might answer Steve's question, but we could probably do another quick one.
Yeah, Steve, can you hear me?
Yes.
Okay, hi, this is Jenny Marshall from Children's. On a positive, I will say we had, for our EP cases, we had just started the telemedicine program about 6 months before COVID hit. And we had already seen a huge cost savings and a huge increase in parent satisfaction and patient satisfaction with, for just doing, pacer checks, that kind of thing, which can all be done via telehealth. And especially for a lot of our patients that are in Great Bend or, or like Western Kansas, that kind of thing. It's a huge benefit as opposed to having to drive all the way to Kansas City. So, and then obviously with COVID, that just exponentially grew the amount of satisfaction we got from our families. So I will say in the EP pediatric population, it's been huge for us.
Yep. Very good. I'm sorry, go ahead.
At North Kansas City, we had planned to go live with a telemedicine stroke specialist cart for our code strokes that come in through the ER, as well as our inpatient code strokes. And of course, COVID hit and kind of delayed everything, but we went live with it anyways during the pandemic. And overall, it's been pretty successful, but we did hit, a couple of bumps in the road here and there. So we're hoping to smooth things out continuously as we go along, but overall positive.
Great. I'll share just one quick one that I'm still fascinated with as even living in this stuff for the last 25 or 30 years. And that was a patient that we saw for a very complex situation at KU that lives in Western Kansas, a farmer, a big farmer. When he needed his follow-up, he was not in a position where he could leave the harvest, which was a year ago. I think it may have been a year ago this month. Didn't want to leave the harvest to come all the way to Kansas City for a visit. He actually did his follow-up visit from the cab of his combine out in the middle of the wheat field. So, that is the perfect use of technology. The physicians here and the specialists here got the information they needed from him to manage his care, possibly adjust his medication. He did not have to drive 4 hours here and 4 hours back. I think that is a perfect use of technology going forward. So hats off to him in the cab of his combine. Thanks, John.
Yes, Ron, did you have one quick question before we go?
Oh, sure. And Steve, thanks. And just to add to that, I've had a number of interactions with primary care through telehealth, and it's been terrific.
Good.
It's just the idea of being able to save you on simple questions. It's a terrific thing. In fact, I would add, what we've discovered mostly around telehealth in some of the work that I've done is that it isn't a technical issue. It is all about, new systems and processes and actually even getting patients used to the idea of what can be done. My quick question was, it's related, but I'm curious, Steve, if there's any discussion around hospital at home in your work around telehealth, if that's something that's entered this market at all or is part of the conversation.
Great question. And Ron, the answer is yes. A lot of discussion about hospital at home. I think it's one of those areas where health systems like University of Kansas Health System, as well as others, are starting to see that if they're even chronic patients or even acute patients that could shorten their length of stay and be cared for at home. I think a big question there is certainly reimbursement. Here in the Midwest, we are still a fee-for-service program. On both coasts, they're way ahead as far as those risk-based contracting or accountable care organizations. So as that evolves, I think you're going to see more of that here in the Midwest. But you're spot on with the question. If I can convalesce, if you will, at home, maybe with supported oxygen and durable medical equipment in my home with a nurse that can either visit in person or a provider that can see me by video, I think that's a direction that you're going to see healthcare moving over the next few years.
Okay.
Okay, great. Thank you very much, Steve, and also Gary for your presentation. It really was very effective and very exciting for this community. It's an area that actually KC Digital Drive was founded to help address, was opportunities for telehealth in the Kansas City region. So we're very grateful to you for your input. And now I'd like to shift tracks kind of dramatically, but and for me, I'm very excited about this next opportunity of learning. We have a group here that's very interested in the uses of data. And also we've not before had the opportunity to look at work inside the field of imaging. And so with that, we have with us Josh Miller from Gradient Health, CEO and co-founder of Gradient Health, to take us through their solution and how they help drive the artificial intelligence behind imaging today. So Josh, please take it away.
Sounds great. Good to meet everyone. I'm Josh. I'm the CEO of Gradient Health. We're normally based in Durham, North Carolina, but I'm in South Florida today. We don't have that much time left, so I'll dive right into a quick presentation.
You're good for another 35 minutes, Josh.
Okay, cool. So let's go ahead and share my screen here. Is my
you just
deck showing up okay?
There you go.
Okay, awesome. Well, great. So I want to talk to you about a problem in the space today, which is that there are tons of companies out there that are trying to automate radiology. So what do I mean by that? I mean that they're trying to build AI that does things like automatically detects tumors or automatically detects broken bones. Tons of companies are investing in the space. There's about $6.5 billion flowing into the space. So the question you have to ask yourself is, hey, if so much money has been going into this, why don't we hear a lot of this stuff actually making it into the hospital setting? And the answer to that is, in order to train an AI, you need something called labeled data. So what do I mean by labeled data? I mean stuff like this. For an AI to be able to pick out a broken bone, you have to show that AI a bunch of examples of what broken bones look like. This is an example of our software where someone's doing the labeling, which we'll get a little bit into later. But this is a big challenge. Companies like GE, Siemens, and Philips sometimes spend over $1 million in 12 months just to assemble the labeled data set. We're able to do the same exact work in about 1/3 of the time and for 1/3 of the cost. The reason this is such a big problem for these companies is, hey, the raw data, the unlabeled data of the patient images is usually locked up in hospitals. The software to label that data is still desktop software today, so it's pretty difficult to get that data labeled. And then finally, you need an actual radiologist to do this kind of data labeling for the AI to be as good or close to as good as a radiologist. And across those three problems, that makes this a really expensive, difficult, and slow thing to do. So when I talk about the players that are doing this in the space, I'm talking about not only GE, Siemens, and Philips. You've got a handful of startups in the space, about 500 of them, that are all trying to produce radiology AI and have raised tens of millions of dollars or more just to produce a single AI. You've also got NIH labs that are getting their R01 grants to go ahead and produce this kind of data. So what is Gradient Health? We're a platform for producing that labeled radiological data much cheaper and in a smaller amount of time. We do that by bringing together patient images from hospitals around the world. Right now, we have about 300 million patient images. We put that together with really good labeling software that looks exactly like a DICOM viewer that a radiologist would use in a hospital setting, but it runs in the browser. And then we brought together radiologists from all over the world in China, Russia, Brazil, to actually do this kind of labeling, which typically US radiologists are too expensive for. So here's what it actually looks like for one of those customers. If you're someone like GE and you want to develop an AI that does something like evaluate prostate cancer. Normally, GE would spend about 6 months and $500,000 calling up all of the different hospitals that might have this data to assemble the unlabeled data. They'll then spend about $1 year and $1 million labeling that data set. And by the time that they're ready to start actually developing an AI on that labeled data set, they're already 12 months in and more than $1.5 million. With us, they come to us, we've already got the data assembled from the hospitals. So it takes us about 1 day to pull out that unlabeled data. They spend about 50 grand on that. We label that data with our software. And that takes us about 3 months and 300 grand. And then all in all, it comes out to less than 1/3 of the cost and less than 1/3 of the time to actually assemble one of these labeled data sets for GE. Here's how it actually works. They license the data from us, they license our software, and then they pay a services subscription to actually get access to those radiologists to do the labeling. So here's where we are today. We're a relatively small startup. We've only done 220,000 in revenue so far, but we've only been around for 12 months. So there's a big need for this already. The fact that we just got started and have people using it is great. Here's our team. It's me and my co-founder, Owen. We've been best friends and co-founders for about 9 years now. Started and exited a company in the agriculture space for machine learning. Would have been about 3 years ago. We've got a crack team of advisors, mostly from our time at Duke. We've got the CMO of United Healthcare, some folks from the Duke Institute of Health Innovation, and Google. But that's it. We're a startup. We're currently raising around right now. We're raising out $2 million to get to about $3 million in revenue in 2 years. That's going to let us hire a team of engineers. We're going after these NIH labs that are doing this kind of research, as well as a couple of those large enterprises like GE and Siemens. But we don't want to just stop there. So we're starting with radiological data and building labeled data sets in radiological data. But we want to do this for all medical data. The idea here is there's tons of EHR data, oncology data, pharmacological data, radiological data that's out there and steadily becoming more available. But the problem is that data alone isn't all that useful. It needs to be cataloged, tagged, and labeled in the same way we're doing for radiological data. So that's us. That's what Gradient Health does. We're starting out by producing labeled data sets for radiology AI. People are loving it so far, and we're going to be moving into doing all of medical data over the next few years. But let me pause there and see if there's any questions.
Great, Josh. Thank you. Where did that great repository originate? How were you able to capture so many millions of images?
Yeah, so we partnered up with a hospital system based in China and a hospital system based in India, and de-identified all of that data out of their systems for usage.
I see.
Yep. We're not stopping there though, because obviously Chinese and Indian data isn't representative of the global population. So we're working towards aggregating data in the US, Canada, South America, Europe as well.
Would you see health systems as a client, or would it be mostly larger labs and other kinds of researchers?
Yeah. Academic hospitals really like our software because a lot of them will be doing this kind of research where they want to develop an AI for radiology to make their own radiologists more efficient. So that's been a good amount of our customer base to date. We also, for these academic institutions that, let's say, already have a PACS system with de-identified data, we can essentially help them monetize that data as well as an additional revenue stream. So let's say you're a hospital that works on a particular rare cancer. They contribute their data to our data set. And let's say someone else is developing an AI to detect that kind of rare cancer. They're able to access that original hospital's data for a fee. And then we share that revenue with the hospital.
Hey, Josh, this is Steve. Great presentation and best to you guys. I saw a similar presentation, maybe not on the scale that Gradient is pursuing, but for dermatology patients. Yeah. Being able to map someone. I don't know if that's on your radar screen or not, but I know that from a asynchronous type visit, kind of like a radiology visit is, dermatology is ripe for AI to come in and help out.
Definitely. I guess my answer to that would be, it's a great idea. Radiological data, or sorry, dermatological data is not usually stored in DICOM format. And so it's a lot, and they're not these huge gigabyte mammogram images. So that it's not as hard to deal with. So there's a lot more players in the dermatology space than there are in the radiology space when it comes to this kind of stuff. But eventually we would want to actually do some work in dermatology.
Is the next most logical step laboratory or not?
Sorry, what do you mean by that? Are we going to be doing
laboratory imaging, pathology?
Yeah, we could move into pathology. That would be kind of the next most logical step. we would probably also move into like specific oncology data as well.
Others from the team.
Hey, Josh, this is Anurag. I had a question about your data set and some value that you had put on it based on, I think, the GE example. I don't remember exactly, but did you say you had about 3 million DICOM images or X-ray images?
300 million.
Okay, so then it's even a factor larger. So like, I mean, you're talking about over $1 billion of valuation on those imaging based on the GE example. Isn't there a way to monetize on just the data itself?
Yeah, but it's better to come a step downstream, right? And actually do the labeling of the data, because that allows us to service these like mid-sized companies as well. So someone like GE might have radiologists on staff, but your typical NIH lab or even radiology startup might not even have a radiologist to do the labeling on staff. So that's why we don't just sell the raw data itself. We sell the labeled data. We have done transactions in the past where we just let people buy raw data, but I would say that's atypical.
So is all of your data set labeled already?
No. So typically what happens is someone rings us up and says, hey, I want a rib fracture data set, right? Labeled. We'll pull out all the rib fractures we know we have because they're actually from a hospital system with radiology reports. So we know there's a rib fracture in the image. Then we'll have our radiologists sit through and actually annotate it, and then we'll deliver the data set. So it's not like it's all pre-labeled. Someone calls us and says, hey, I want this labeled data set, and we'll put it together for them.
Gotcha. And then is the expectation from your perspective that eventually you guys will just have an automated system that will do the labeling? So once you get enough rib fractures labeled, you'll figure out how to label it yourself?
Yeah. You have a really good point. I don't think we'll get to the place where automatic labeling will be perfect. What we're working on is something called active learning, where let's say you have 1,000 images to label. If we have someone label 5 of them, then the next 995 images can just be a yes or no question, right? Did we label this correctly or not? You'll still always have to have some kind of human in the loop doing this data labeling, but we're doing things that make the labeling faster. Just probably it'll never be completely automatic.
Gotcha.
Mm-hmm. Okay.
I was just wondering, are there, from your existing client base, is there any kind of success story or anything like that that you can share?
Yeah. So we've had some really cool successes so far. Mostly people working on lung CT images, trying to do things like automatic nodule detection or detection of certain pathologies in the lungs. So we have CT data that can't really be found in many other places. And so that's attracted a lot of customers to us. So they had told us, I'm thinking about 3 customers specifically, each of them were spending about $500,000 to get a labeled lung nodule data set. We were able to get it to them for under $100,000 in 15 days, as opposed to the 6 months they'd been doing before.
Wow, that's tremendous.
Yeah. So the idea and kind of the mission of the company today is these radiology AI companies, we know they're important, but they're just not able to move quickly because of the lack of data. So we're kind of greasing the wheels on their behalf and allowing them to compete in this space.
Josh, if you wouldn't mind, we got a request from Anurag who just asked the question, if you could share your email in case people have an opportunity to follow up with you.
Definitely. Josh@gradienthealth.io. Cool. Oh. There you go. Awesome. Any other questions or anything anyone would like to see? I could run a quick demo here of what the software actually looks like. So what you're seeing here is someone labeling a prostate image. You're seeing they're doing the actual labeling in 2 dimensions. And what happens is, and this is right in Google Chrome, this is right in the browser, which for any of you that know about dealing with DICOM data and data this size, it's really, really difficult to manage and deal with this stuff in a browser and not on a desktop application. But you're seeing a 3D rendering of the prostate being labeled in real time, right in Google Chrome here. Yeah, that's the special sauce we've got.
That's great.
Cool.
Any other questions from the group? This is, as I said, it's kind of exciting for me to just to get into imaging. We've not touched it for a long time, so it's fascinating.
Definitely. Well, great. If anyone has any further questions, you're welcome to shoot me an email, and always happy to chat.
That's great. Thank you, Josh. Really appreciate it.
Yeah, thank you.
For those who had asked about the PCs for People contact, I put the link in the chat to their webpage. They're a group that has locations in several parts of the United States, but primarily the Twin Cities, but they connected here with a group called Connecting for Good and merged their operations. And the link will take you to how to contact them and follow up for patients and clients that you might have. And I am happy to, I'll put in my email address as well. You have it from the invitations, but I'll do it here again for any other questions that you might have with respect to that.
Sounds good.
Okay. So we're set for next month. We will be looking for one of the presentations. We'll be looking at Sarah Health, a startup here in the Kansas City area, and we're looking possibly for another presentation from Children's Mercy as well for next month's meeting. Just mark on your calendar the December and November meetings. We're going to merge into one meeting on December 8th. So if you want to put kind of a placeholder in your calendars for that, we will be holding our November-December meeting on December 8th. But we will indeed have an October meeting at the last Wednesday of the month as usual. So thanks to everybody for your participation today. It was really great to see you all, and particularly enjoyed our presentations, really stimulating stuff. And glad we had the opportunity to have you share that with us today, Steve and Josh. So much appreciated. And I'll sign off from there. Thanks very much.
Thank you.